Good afternoon to all of you. I welcome all the consultants. I welcome all the consultants, PG trainees, and all others with us today for this second meeting of case discussion. Last month, we had our first case discussion meeting successfully, and hope you all benefited from it. This case discussion meeting was suggested by Curriculum Revision Committee of PGIM and the College of Chemical Pathologists of Sri Lanka. Happy to organize these case discussion meetings for you all. I'm sure you all come across many difficult and interesting cases daily during your routine work. Please use these meetings to share those valuable experience with each other. I request all of you to send details of your interesting cases to college, and we will organize this meeting and accordingly we will inform you in advance. I must thank all who have sent cases for this meeting today, namely Dr. Paslas and Dr. Madhubashini, Senior Registrars of National Hospital of Kandy, and Dr. Thirini, our postgraduate trainee attached to National Hospital of Kandy. I would also like to thank Dr. Dulani Jayawardana, Consultant Chemical Pathologist of National Hospital Kandy, for valuable contribution for this event. Hope this will be valuable learning experience for all of you. Over to you, Paslas, Madhu, Bashini, and Thirini.
Thank you, Kisari. I must thank the college for giving this opportunity. Can you all hear me?
Yes, Dulani, we can hear you.
Can you see now? Slides are moving.
Yes, it is moving now.
Yeah, right. Okay. I must first thank the college and for giving this opportunity and for arranging these case discussions. I think today we are going to discuss 3 cases, and the objective is these cases are mainly about the multidisciplinary approach for the diagnosis of difficult patients with the selective venous sampling, and 3 different case scenarios are there. So I must emphasize all trainees and to understand the role of chemical pathology in this diagnostic workup, in the dynamic function test, in ensuring quality assurance in the pre-analytical phase, and the interpretation of results. So we have to identify the importance of the relevant protocols for each and every workup and the guidelines, so it will be more useful for the practical situation, our contribution for the diagnosis of these patients as well as for the education purposes. So first I invite Dr. Fastas to continue with the presentation.
Good afternoon, everyone. This is the first case. This is regarding a man with recurrent early morning unresponsiveness. A 29-year-old previously unevaluated male presented with 3 episodes of early morning unresponsiveness associated with excessive sweating. He had these symptoms over 6 months. All episodes were associated with skipping of his dinner and recovering after having a cup of tea. He denied any use of oral or injectable hypoglycemics, including insulin, and also denied abuse of alcohol or illicit drugs. He had no significant past medical history like seizure and also had no significant family history. His physical examination on admission was unremarkable. The development of symptoms following skipping of his meals and recovery of symptoms following taking a cup of tea, that is a sugary drink, gave the suspicion of a hypoglycemic attack. However, he did not have any documented low glucose levels. This is the causes of hypoglycemia in adults given in the Endocrine Clinical Society guidelines. This is divided into two: ill or medicated individuals and seemingly well individuals. In medicated individuals, the major causes are drugs with insulin or insulin secretagogues, that is sulfonylurea, and alcohol. And in patients with critically ill like hepatic, renal or cardiac failures, and patients with septicemia, and hormone deficiencies like adrenal insufficiency, and in seemingly well patients, the major causes are endogenous hyperinsulinism, in that the major cause is insulinoma, and other functional beta cell disorders like nesidioblastosis, and other causes like insulin autoimmune hypoglycemia and antibody to insulin or antibody to insulin receptors, and accidental intake of hypoglycemics. This is our patient's basic chemistry. Here sodium, potassium, calcium, 9 cortisol and the thyroid profile all were within the normal ranges. As the next step, he was undergone 72-hour observed fast test. During 72-hour observed fast test, he developed symptoms of hypoglycemia at around 12 hours of fast. At that time, the glucometer reading was 45 milligram per deciliter. At that time, venous blood was taken for plasma glucose, serum insulin and serum C-peptide. This is his 72-hour observed fast test results. Here, the plasma glucose was 42 milligram per deciliter with inappropriately high insulin of 194 picomoles per liter or 32 milli international units per liter with a high C-peptide of 1.27 nanomoles per liter. According to the guideline, proinsulin, beta-hydroxybutyrate, insulin autoantibodies and screening for sulfonylurea should be done. However, we could not include these tests because of the unavailability of the test. In his imaging, an ultrasound scan of the abdomen did not reveal any pancreatic lesion. Computer tomography with contrast showed no evidence of insulinoma of the pancreas. An endoscopic ultrasound scan of the pancreas revealed a 20 millimeter hypoechoic lesion adjacent to the portal confluence and on the left side of the splenic vein. And no any other lesions were found in the rest of the pancreas. As the next step, to confirm the hyperfunctioning of the identified lesion, he was undergone selective intra-arterial calcium stimulation test. Here, calcium is injected into selectively cannulated major pancreatic arteries and blood samples are taken from the hepatic vein for insulin and C-peptide. It's a highly invasive procedure. The stimulation is done in protohepatic, gastroduodenal, distal splenic, proximal splenic and superior mesenteric arteries, and samples are collected from the hepatic vein at before and after 30, 60, 90, 120 and 180 seconds of the calcium injection. This test is based on the stimulation of insulinoma cells by the exogenous calcium and secretion of stored insulin into the circulation. A two-fold step up of insulin concentration at any point from the basal value suggests the location of the lesion in the territory of the particular arterial supply. A positive response following the stimulation of gastroduodenal and superior mesenteric arteries localizes the lesion to the head and neck of the pancreas. Stimulation of proximal splenic and distal splenic artery regionalizes the lesion in the body or tail of the pancreas, and a positive response in the protohepatic artery suggests the presence of hepatic metastasis. This is our patient's report. Here, the positive response was seen following the stimulation of common hepatic artery. Here the stimulation was done in the order of protohepatic, common hepatic, gastroduodenal, distal splenic, proximal splenic and superior mesenteric arteries. The pitfall of our examination was stimulation of the common hepatic artery, which is not routinely done because it does not directly supply to any region of the pancreas but gives away both protohepatic and the gastroduodenal arteries. However, neither the protohepatic which was stimulated before common hepatic nor gastroduodenal which was stimulated right after common hepatic showed a positive response. The possible explanation could be gastroduodenal might get parallelly stimulated along with the common hepatic, leading to the release of insulin from the region supplied by the gastroduodenal artery. But when the gastroduodenal was stimulated directly within a short period, there might not be adequate stock to get released and it did not show any response. With the above postulation, we concluded that insulinoma was in the region supplied by the gastroduodenal artery. It gave a path for screening for the tumor in the head, neck or its close proximities. These are the graphs of insulin and the C-peptide response. Here in the orange color describes the common hepatic artery and it shows a very high response. Both insulin and C-peptide shows very high response from the basal valley. During the surgery, with a bimanual palpation and intraoperative ultrasound scan, a 2 into 2.5 centimeter tumor at the splenoportal confluence with proximity to the pancreatic duct was identified and he underwent spleen preserving distal pancreatectomy. His post-operative period was uneventful except for mild hyperglycemia and he was started on a small dose of soluble insulin. Histology revealed a well-differentiated grade 1 neuroendocrine tumor with diffuse cytoplasmic positivity with synaptophysin and chromogranate. Those are the IHC markers for neuroendocrine tumor we are using. During follow-up, insulin was omitted and his last hemoglobin A1C was 5.3%, which was normal. Over to you, madam.
So thank you, first class. So this the case about a previously healthy person, and he is not a diagnosed patient with diabetic or any other illness. And with the history, we can elicit that he had fasting hypoglycemia, though it is not documented with measurement of blood glucose value. So we have to discuss possible diagnosis for the fasting hypoglycemia. So in these cases, the basic tool for the demonstration of hypoglycemia is the Whipple's trait. So there, the more emphasis is on the patient's clinical history and the signs and symptoms that is consistent with hypoglycemia. And we also need low blood glucose levels measured and documented. And there should be a correction of hypoglycemia following intake of sugar. So during a spontaneous hypoglycemic event, if it can possible, we have to measure the blood glucose value and we have to take samples for those analytes, glucose, insulin, C-peptide, proinsulin and beta hydroxybutyrate. That is because as first as discussed in the case, the possible differential diagnosis, the causes for the hypoglycemia we have to exclude. And again, we have to take samples for the screening of the drugs that is possible for the hypoglycemia induction, like insulin secretagogues and the insulin autoantibodies. And then observe the plasma glucose response after injection of glucagon. So the dynamic function test that we use here is the observed fast test. So because sometimes he might not able to collect the samples during a spontaneous hypoglycemic event. So we have to recreate that situation, and we recreate this by 72-hour fast observed test. Right? So the procedure for the test, usually we advise them to admit the patient, or else it can be done in the outpatient department with the availability of the emergency treatment. In the morning, patient is advised to take light breakfast, water or caffeine-free drink. Then the patient is kept fasting. Then after 4 hours interval, blood glucose is done with glucometers. Right? When the blood glucose goes below 60 milligram per deciliter, then glucose should be checked 2 hourly. When the glucometer value shows blood glucose value less than 55 milligram per deciliter, or when the hypoglycemic symptoms develop, then we have to collect venous blood for random blood glucose, insulin and C-peptide. In this place, we have to ensure that we have collected samples into the proper tubes and proper volume, and we store or transport them in the correct temperature, in the correct procedure. So it's the responsibility of the laboratory. So if the facilities are available for the analysis, we have to collect samples for proinsulin, beta hydroxybutyrate and insulin autoantibodies for the screening for sulfonylurea as well. After that, the collection of samples, we can give 1 milligram IV glucagon. Then blood is drawn for plasma glucose following 10, 20 and 30 minutes. After that, patient can be asked to get food, and before discharge, we have to ensure the normoglycemia of the patient. So that is the procedure for the 72-hour fast test. Then once we get the results of this test, we can see what are the results that we have got for these tests. Like we have the glucose value that is less than 55. Then we have the insulin, C-peptide, proinsulin. If possible, we can get the other parameters, beta hydroxybutyrate and the antibody levels or the any drug levels. So if when the hypoglycemia is there, that is glucose less than 55, at that stage, if the insulin is less than 3, and the C-peptide less than 0.2 nanomoles per liter, and the proinsulin is also low, this indicates that patient is normal. And if it is, if the results comes as when the hypoglycemia is there, right, insulin is high, but C-peptide is low, that indicate that insulin has come from exogenous side. So because if the endogenous production of insulin happens, both insulin and C-peptide should come into the patient's blood. So if it is not there, that means the exogenous insulin. Then the other case, you get the hypoglycemia in the patient and you have the results, insulin is high, more than 3, and C-peptide also high, proinsulin also high, and if you can measure the beta hydroxybutyrate, it's low. So there is no other hypoglycemic agent, so it indicates the insulinoma as in our cases. So it goes on. So you can see there is a method of interpretation of these results. We have to take all the results together and put it into the patient's clinical picture and then give constructive interpretation for the patient. So this is again our patient results. You can see as given in the table, he has high insulin level, units given both picomoles per liter and MIU per liter, and the C-peptide also high. So we concluded that patient is having insulinoma. Once we confirm that patient has got insulinoma, then we have to find where is the culprit. So where is that insulinoma producing tumor exactly. So we can first go ahead with the non-invasive modalities like CT or MRI. But as these tumors like insulinoma are very small, less than 2 centimeter. So the detection by the CT or MRI is very low, sensitivity is very low. So then we have to go for the invasive modalities like endoscopic ultrasound scan and the intra-arterial calcium stimulation test. So when we discuss about the intra-arterial calcium stimulation procedure, we all must have a very good idea about the anatomy of the pancreatic arterial supply. As first as described in the case, the stimulation is done using catheters sent to this arterial bed for the stimulation by calcium gluconate. You can see in the here one catheter is inserted into the arterial bed and it will send the calcium gluconate at different places, and there is another catheter in the hepatic vein. So samples are collected for the analysis from here. So once we stimulate various places from here, then we collect the sample from here. So we must ensure that when the catheter in the proper place, we get the sample for the analysis. So the calcium stimulation in major pancreatic arteries and samples are collected from the vein, as I explained earlier. With the time gaps like for the insulin and C-peptide before and following the injection of calcium gluconate, 30, 60, 90, 120, 180 seconds, we collect the samples. So then we must ensure that we collected the samples properly into correct tube and labeled and transported and ensure the accuracy of the results. And if we find that there is a twofold increase in the insulin at any point from a particular region, it regionalizes the tumor to that site. So the role of laboratory to emphasize, laboratory representative must be present at the time of sample collection with the team. Like it can team include endocrinology and the interventional radiologist. So we are part of that team and we must ensure that our role must be played at there, and to make sure appropriate labeling, transportation and avoid any mishandling at any place of the analysis cycle. And there must be a responsible person in the laboratory to ensure that analyzer is at QC is okay, analysis ready for the analysis. And on the other hand, these analytes like insulin is highly labile, and stored in the proper temperature -20 for further investigation. So if there are any questions regarding this case, we can take it, or else we can get the question at the end also. Any questions so far? So our next case will be discussed by Dr. Madhubhashini. So I invite her to continue with the next case.
Good afternoon, everyone. This case report is based on adrenal venous sampling, importance of contralateral suppression index in lateralization of primary hyperaldosteronism. A 52-year-old lady who presented to ETU with left-sided chest pain. She was diagnosed to have hypertension for 5 years and treated with losartan, nifedipine, and spironolactone. She had no history of type 2 diabetes and dyslipidemia. Family history was not significant. On admission, her blood pressure was 180 by 100. General and systemic examination findings were unremarkable. ECG showed hypokalemic changes. Echocardiogram was normal. Ultrasound scan abdomen was normal, and no evidence of renal artery stenosis. Basic investigation panel revealed persistent hypokalemia with high urine potassium excretion. Venous blood gas analysis showed metabolic alkalosis. Low-dose dexamethasone suppression test and 24-hour urinary metanephrine levels were normal. Results to safely exclude Cushing syndrome and pheochromocytoma as cause for hypertension. Aldosterone-renin ratio was planned to exclude primary hyperaldosteronism, optimize potassium level, and withheld interfering antihypertensives prior to sample collection. ARR revealed elevated aldosterone and suppressed renin activity with a ratio of 3,312 that confirmed the diagnosis of primary hyperaldosteronism. Since the plasma aldosterone level is very high, without going for a confirmatory test, subtyping was done with CT adrenal protocol. Adrenal CT demonstrated bilateral adrenal adenomas with characteristic enhancement pattern. The diagnostic dilemma has occurred following imaging finding whether it is a case of bilateral aldosterone producing adenomas or unilateral aldosterone producing adenoma with contralateral non-functioning tumor. In the next step, adrenal venous sampling was done to lateralize the hyperfunctioning lesion. Samples were obtained from femoral vein, right and left adrenal vein under radiological guidance and analyzed for cortisol and aldosterone concentrations. Sensitivity index was calculated for both sides. Sensitivity index in right and left side were 1.38 and 3.02 respectively. Results were suggestive of successful cannulation on left and failed cannulation in right side. Since one side cannulation is failed, lateralization index could not be calculated. As a consequence, we were compelling to calculate contralateral suppression index in view of demonstrating the suppression size. Contralateral suppression index was calculated by cannulated side adrenal vein aldosterone to cortisol ratio divided by peripheral aldosterone to cortisol ratio. The contralateral suppression index was 0.16 in our patient. If it is less than 1 in unstimulated AVS, suggests the suppressed aldosterone secretion in cannulated side. Therefore, in our patient, left side adrenal gland was suppressed with possible hyperfunctioning aldosterone producing adenoma in right side. Based on contralateral suppression index, patient was offered right side adrenalectomy. Following surgery, she became eukalemic and aldosterone level came back to reference limit, and histology confirmed the adrenal adenoma. Thank you. Over to you, madam.
So this is in this case is the case with hypertension. So the adult patient coming with the hypertension. As you all know, the hypertension is the one of the commonest non-communicable disease. It's highly prevalent in the world now. According to the WHO, around 1.3 billion people from the world population suffering from hypertension, and it's account for the 31.3% of all adults. So when we consider patients with hypertension, the prevalence of primary aldosteronism, it's account for the 5% of patients with hypertension. And if we narrow down it to the patients with resistant hypertension, it will be 20% of patients. So it's very important to identify the primary hyperaldosteronism in the patients with hypertension. So according to the current guideline, they say at least once we have to investigate for the primary hyperaldosteronism in the patients with hypertension. So the hallmark features in the primary hyperaldosteronism, as the name implies, it's the increased aldosterone. So with the secretion of aldosterone, there will be a volume expansion. So volume expansion will cause hypertension. But the mortality and morbidity not only due to that, because the aldosterone acts as a pro-inflammatory marker, and it can cause damages to the blood vessels, heart, and the blood vessels in the kidney. So finally, it will lead to the renal failure and the problems in the heart and causing cardiovascular events. So the hallmark features that we consider in the primary hyperaldosteronism is the hypertension, elevated aldosterone, and the suppressed renin. but we commonly see the although we see hypokalemia in those patients, but not all the patients with primary hyperaldosteronism comes with the hypokalemia. So the causes for PA, the common causes are the bilateral idiopathic hyperaldosteronism. It's account for the 60% of patients, and the other common cause is the unilateral aldosterone producing adenoma. So APA, it's around 30%. The rare causes that we have to consider unilateral macro or micronodular primary adrenal hyperplasia, aldosterone producing carcinoma, or the familial hyperaldosteronism. Those are the rare causes. So the diagnostic approach for the PA, commonly we can initially we have to go with the screening test. So that is the ARR, aldosterone to renin ratio. Once we do the screening test with the available results and the patient findings, then we can decide whether to go for the confirmatory test like saline infusion test, oral sodium loading test, and the uncommonly used cortisone suppression and capropil challenge test. So we commonly use the insulin infusion, saline infusion test, and then we have to measure the serum blood aldosterone level. But with the oral sodium loading test, we give the patient high salt diet for around 3 days. Then we have to measure the 24-hour excretion of aldosterone. So both can be done for the confirmatory test. Then comes the subtyping. Actually, it is for the localizing of the tumor, which site, which place exactly. So for that, we have to use the adrenal CT protocol with the imaging, or else we have to go with the adrenal venous sampling. So the preparation for the ARR, as the laboratory people, when the request is received for the ARR, we have to always advise the patient or the relevant clinicians regarding the preparation for the ARR. So we must all know all these things for the information to be given to the relevant stakeholders. We advise ambulate for 2 hours, followed by 1 to 20 minutes rest prior to the sample collection. So we ask the patient to be seated, and earlier we asked them to give liberal salt intake and optimize the potassium level if possible, but it's not compulsory. And any interfering drugs, because for the aldosterone to renin ratio, we are measuring renin and the aldosterone. For most of the drugs that we have given for the control of the hypertension can cause any alterations in renin and the aldosterone levels. So we ask the clinician to consider possibility of omitting these drugs, at least for these periods. But in the practical situation, we have seen that it's very difficult to control, especially patients with resistant hypertension, and omitting of these drugs is impossible. So in those cases, we have to always do the test while on the drugs and interpret accordingly, considering the possible alteration that can happen with that particular drugs patient is on. So this is the guideline that workflow that we follow for the measurement. So in the patient is having hypertension, they say all patients with hypertension should at least test once to consider the primary hyperaldosteronism. So the screening test is done as we described. Then we get the values for the plasma aldosterone concentration and the renin activity or renin concentration. So these the actual values, not only the ratio, we have to always pay attention for the values of the aldosterone concentration and the renin activity or the renin concentration, and interpret accordingly with the ratio. So if the patient we have to go for the confirmatory test if the spontaneous hypokalemia is absent and the primary aldosterone concentration is not tally with the diagnosis, and we have to go for the confirmatory testing to confirm the diagnosis. In the subtyping, of the primary aldosteronism, first we have to consider CT scan, and if the patient is possible with the surgery, it can localize for the unilateral nodule. If the surgery is possible, we have to go for the AVS and then confirm the diagnosis for that site. Then we have to decide whether it is possible with the unilateral laparoscopic adrenalectomy or the go with the medical therapy. So this is the workflow for that. And the limitations of the CT adrenal, as discussed earlier, because in the case it also described that we can't distinguish between functional and non-functional tumors, and subjective misinterpretations of nodular hyperplasia as aldosterone producing adenomas and vice versa can happen. Then the procedure for the adrenal venous sampling. So here also interventional radiologists, they use catheterization for the sampling, and so it's a multidisciplinary work approach, and we have to be there as a part of the team, and we have to receive the samples, ensure proper labeling, collection and transport, and as well as the analytical aspect, we have to assure that we produce accurate results with the quality assurance and the reporting with the interpretation. You can see in the diagram as described in our case that right adrenal gland vein, the acute angle and the small caliber, the sampling is very difficult, but in the left side you can see you can have a easy access for the sample collection. So AVS can be performed in two ways. It can be done with ACTH stimulation or without ACTH stimulation. So in the ACTH stimulated AVS, why we use this is we have to give a continuous infusion starting 30 minutes before sampling and continuing throughout the procedure. And the rationale for the use of ACTH stimulation: first, to minimize the stress induced fluctuations in the aldosterone secretion during our sampling process. Then to maximize the adrenal to peripheral cortisol gradient, by that confirming the successful sampling, and to maximize the secretion of aldosterone from APA. So the interpretation of unstimulated AVS has been done in our case. We had to do some calculation using the results we have obtained from the samples collected during the AVS. So we can calculate the sensitivity index. Sensitivity index is the calculation done by dividing the adrenal vein cortisol concentration by the peripheral cortisol concentration. So we have to calculate it for both sides, right and left, and then we have to interpret. If it is more than 2, it confirms the proper catheterization of that site, and if it is less than 2, it indicates the failure. Then the lateralization index is another calculation. So it indicates, we calculate by using the aldosterone, dominant side aldosterone to cortisol ratio divided by non-dominant side aldosterone to cortisol ratio. So it used to overcome the dilution effect due to the anatomical variation in the left and right adrenal veins, and again if it is more than 2, it indicates the dominant side aldosterone producing adenoma. Then comes the another calculation, that is again that is the data that we have collected by using the samples. So we can do these calculations and give certain interpretations for the clinicians or the surgeon regarding the possibility of the location of the tumor. So the contralateral suppression index CSI calculated by cannulated side aldosterone into cortisol ratio divided by the peripheral aldosterone to cortisol ratio. So CSI, if it is less than 1, it indicates that suppressed contralateral gland in cannulated site. So it indirectly implies there is an excess aldosterone secretion focus or dominant gland in the opposite side. So, so in those cases, we can use this index for the localization of the tumor. And in the ACTH stimulated AVS, the lateralization index we can use if it is more than 4 into 1, it indicates unilateral aldosterone excess. If it is less than 3 into 1, it indicates bilateral idiopathic hyperplasia. But there is a gray zone that we can't use, that is if it is more than 3 and less than 4, that is the gray zone, but then we can't use it to lateralize confidently. So in these cases, we can again calculate CSI as follows. CSI, the non-dominant side aldosterone to cortisol ratio into peripheral aldosterone to cortisol ratio. So again, if it is less than 1, we can use to find the non-dominant side. And the research evidence says that it is there is a 97% good surgical outcome with the use of this in the ACTH stimulated AVS using this one. So the conclusion with this case that we can arrive, so AVS is a technically demanding and operator demanding procedure. So there is it can be done in certain centers with the facilities, and there must be an experienced, well experienced person who can do proper catheterization. And so because of the right side vein problem, the bilateral cannulation is not possible always in the AVS. So right cannulation is difficult due to small caliber acute angle in the right adrenal vein. So we can help them with the calculation CSI, and it will be useful in the interpretation of results in places where unilateral cannulation has happened. So thank you. So any questions regarding the case?
Dulani,
Yes, madam.
Dulani, yeah, thank you for that interesting explanation and the history. Now, listen to say, now, did your patient, was the patient on antihypertensives, your patient?
Yes.
Yes, Madhupashini. The patient was on
Yes,
drugs.
patient was on antihypertensives, losartan, nifedipine, and spironolactone.
So you managed to hold them
Before ARR, we hold them.
for how long? This is the main problem doing these ratios. For how long did you hold the antihypertensives?
This is in this patient we were able to hold the drugs for around 1 week, madam, and
Ah,
as the results is really indicative of, then we didn't had any problem. But the problem is with the marginal cases that we also come with similar cases that we can't.
yeah,
Yeah,
it's very difficult.
yeah, difficult, madam.
Yeah, thank you.
Thank you. So we will go ahead with the next case. I invite Dr. Thilani to continue with the case.
Thank you, madam. Good afternoon, all of you. Persistent hypercalcemia following parathyroidectomy. 23-year-old man admitted with acute abdomen and diagnosed to have acute necrotizing pancreatitis. It was his second admission with acute pancreatitis. He was a non-alcoholic. In between those two episodes, he had a history of acute kidney injury following obstructive uropathy. Ultrasound scan KUB revealed that left side multiple renal stones and right side hydronephrosis with pelvic-ureteric junction obstruction due to ureteric stone. He was undergone right side double J stenting and then improved. He had a past history of constipation. He was not on any continuous medications like lithium and diuretics. On acute presentation, he had hypotension, tachycardia, tachypnea, and marked abdominal tenderness. He was investigated for acute necrotizing pancreatitis and found to have hypercalcemia with associated vitamin D deficiency. Corrected calcium 3.12 millimoles per liter and vitamin D levels 15.9 nanogram per milliliter. It was documented as deficient and replaced with mega doses. So we came to diagnosis that hypercalcemia induced acute necrotizing pancreatitis. This is his biochemical test reports. Corrected calcium 3.12 millimoles per liter, low phosphate 0.75 millimoles per liter, elevated intact PTH 212 picograms per milliliter, elevated alkaline phosphatase 144 international unit per liter with normal magnesium and creatinine levels, and urine calcium creatinine clearance was 0.02, exclude the benign familial hypocalciuric hypercalcemia. Basic biochemical panel showed hypercalcemia, hypophosphatemia, elevated alkaline phosphatase, elevated intact PTH with normal creatinine levels warranted the diagnosis as primary hyperparathyroidism. So he underwent further investigations. DIXA scan showed a low mineral density for his age, particularly in the distal radius region. Ultrasound scan of the neck showed a 6 mm size nodule in the midpole of the right lobe of thyroid gland and failed to locate any mass in parathyroid gland. Technetium 99 sesame B scan too failed to locate any parathyroid adenoma. Reporting was given as no scintigraphic evidence of abnormal focal retention of tracer in parathyroid region of the neck or elsewhere in ectopic location. Clinical and biochemical findings suggested primary hyperparathyroidism, but two non-invasive imaging did not locate an adenoma. So etiology was suspected as parathyroid hyperplasia. As management, he underwent 4 gland exploration. During the surgery, only 3 glands were identified except right superior gland. 2.5 glands were excised. Histology of the removed parathyroid gland revealed normal parathyroid tissues. Post-operative biochemistry revealed elevated corrected calcium 2.84 millimoles per liter and elevated intact PTH 104 picograms per milliliter. Post-operative persistent hypercalcemia and hyperparathyroidism required further evaluation. So he underwent repeat investigations. Ultrasound scan neck showed a 5 mm size hypoechoic nodule within the right thyroid lobe. Technetium 99 sesame B scan showed a focal abnormal uptake in the region of the right lobe of thyroid bed. Fine needle aspiration cytology from the suspicious lesion revealed only thyroid follicular cells. So we proceeded with parathyroid venous sampling to regionalize the parathyroid lesion. We have taken several blood samples for intact PTH from veins of thyroid venous plexus and a sample from femoral vein. There is a marked elevation in PTH level in right middle thyroid vein compared to the other veins. This graph shows the PTH values in venous plexus. There is a marked elevation about 5,000 picograms per milliliter of PTH in right middle thyroid vein. Right femoral vein PTH level was 189 picograms per milliliter. Interpretation of parathyroid venous sampling. A ratio of specific vein intact PTH to peripheral vein intact PTH of more than 1.5 to 1 gives positive predictive value of 72%. More than 2.5 to 1 gives positive predictive value of 75%, and more than 3 into 1 gives positive predictive value of 83%. Widely adopted threshold of at least twofold increase in the value of intact PTH relative to the peripheral vein regionalized the parathyroid lesion. In our patient, there is a 25-fold increment of intact PTH in the right middle thyroid vein compared to the right femoral vein. So PVS regionalized the lesion in the right middle thyroid venous drainage region. It was biochemically proven that the culprit gland was hyperfunctioning right superior parathyroid gland, which was missed during the surgery. So he underwent a redo parathyroidectomy. Intraoperative ultrasound scan of the neck revealed a deep-seated superior parathyroid gland in the right thyroid vein. Right superior parathyroid lesion was excised. Histology of excised parathyroid lesion revealed that parathyroid gland with chief cell hyperplasia. Following resurgery, the patient was improved clinically and biochemically. Postoperative corrected calcium 2.28 millimoles per liter and postoperative intact PTH less than 1 picograms per milliliter. Over to you, madam.
Thank you, Dulani. So this patient is patients with primary hyperparathyroidism, but the presentation is a bit different because patient presented to the surgical unit with acute abdomen and diagnosed as pancreatitis. So it's an unusual presentation. The but etiology for the hyperparathyroidism can cause hypercalcemia, and the hypercalcemia can cause pancreatitis. So we always must bear in mind that we have to always think about the hypercalcemia and the hyperparathyroidism even in the patients presented to the surgical unit with pancreatitis. So the etiology for primary hyperparathyroidism, according to the literature, solitary adenomas accounts for the 80 to 85%, and the multiple gland hyperplasia, it's around 10 to 15%, and multiple adenomas, parathyroid carcinomas are low prevalence. So we have to always consider these possibilities, especially solitary adenomas. Patients with primary hyperparathyroidism, they may be symptomatic or may be asymptomatic. So symptoms can be either due to hypercalcemia or to PTH excess. Although we got the acute pancreatitis in this patient, it's a rare presentation, and we have to always be careful in young patients with acute pancreatitis. And in the history, if there is no any clue for the induction of the pancreatitis like alcohol abuse, we have to always screen for primary hyperparathyroidism. So the elevated or inappropriately normal intact PTH level in the presence of hypercalcemia confirms the diagnosis of primary hyperparathyroidism. So other causes of hypercalcemia, we have to always consider long-term use of drugs like lithium thiazide diuretics, tertiary hyperparathyroidism in patients with renal replacement therapy, and the familial benign hypocalciuric hypercalcemia, multiple endocrine neoplasia, Menn syndrome. So all this we have to consider these causes as well. And for the in laboratory aspect, in these cases we have to measure calcium and the PTH. So when we consider about the calcium, as you all know, the calcium exists in 3 different forms in the blood. It can be free calcium, it can be bound to albumin, and it also present as the complexes with anions like citrate, phosphate, bicarbonate, and sulfate. So by doing the ionized calcium, we measure the free calcium, and for the ionized calcium, we advise patient the sample collection and the transport. We must advise the clinicians and the relevant people regarding the sample collection and transport. For the ionized calcium, we don't advise collect samples without tourniquet, but we advise them to ensure that pH doesn't change. So we advise them to collect the sample to the full amount without any air left in the tube, and transport immediately, or else if there is any delay, transport in ice to avoid pH changes. But if you are drawing blood for the total calcium, we recommend collect the sample without tourniquet or fist clenching to overcome this spurious hyperkalemia. So by using the calcium value and the albumin value in the sample, we can calculate the corrected calcium to minimize the variation. And so all these parameters are important in the assessment of calcium in these patients. And the PTH. So the PTH is the parathyroid hormone. It's a very labile hormone. It has a very short half-life, like 4 minutes. So we have to always think that advise the patient to come to the laboratory for the sample collection, because if there is any delay in the sample transport, the what we measure in the sample in the laboratory may not represent the actual value in the patient in vivo condition. So sample, if there is any delay, acceptable delay, we advise them to transport in the melting ice or in the cool box immediately. Otherwise, we can't accept those samples with delay and without proper transportation. And even during the centrifugation, if you have a refrigerated centrifuge, is preferred for the separation as well. So once we diagnose that patient is having primary hyperparathyroidism, then we have to localize the tumor. That is the most difficult case. So there are non-invasive procedures like ultrasound scan, neck, technetium scan, CT, MRI. But as and the invasive procedures, as we done in this patient, is the selective parathyroid venous sampling. Parathyroid venous sampling based on the assumption that regional venous drainage of each parathyroid gland occurs via the veins in the thyroid venous plexus. So everybody must have a good idea about the anatomy of the venous plexus in the thyroid bed and how the drainage happens from various places. So we collect the sample. The interventional radiologists, they collect the samples from major points like bilateral superior, middle, inferior thyroid veins, then the bilateral upper and lower internal jugular veins, bilateral innominate veins, thymic vein, intercostal vein to exclude any ectopic sites, and also sample from the femoral side, from the pectoral vein. So this diagram explains the names that we mentioned, how it distributed in the thyroid bed. And once we collect the samples from each side, so it is the responsibility of the laboratory person there as the team member to ensure that they get the sample once they collected by the interventional radiologist and properly label and ensure that there is no mishandling of the samples at the site of intervention, and ensure proper transportation and ensure proper analysis at the laboratory as well. So once we get the results, PVS would regionalize the hypersecreting gland, and the threshold levels, at least twofold increase value of intact PTH relative to the peripheral vein sampling, that is sample from the femoral vein, it will indicate the location. So that is about the primary hyperparathyroidism. So with this case, what we have to emphasize is the importance of involvement with dynamic function test and the multidisciplinary approach for the diagnosis of patient, and the contribution we can given to the difficult diagnosis of patients. And also this is a we have to always use the recommended guidelines and the protocols for the interpretation of those results and produce effective report for the clinicians or the surgeons go ahead with. So any questions regarding this case? Yes, madam.
Now this patient was initially diagnosed with pancreatitis.
Yes, patient on admission, patient was admitted to the surgical ward with the pancreatitis, acute
I
abdomen.
see. So they have done amylase. So the amylase was,
Yeah, amylase was high.
and they, okay. And the other thing is, now he had two surgeries. No, the patient,
Yes, madam. Initial one because initially that they primary hyperparathyroidism was diagnosed, but they removed the identified parathyroid glands, but the
oh
the
my God.
culprit gland was not removed with the
Yeah.
initial surgery. Yeah, that's why we have to go ahead with the venous sampling to locate the tumor and then proceed with the second surgery.
Yeah, yeah. So after the initial surgery, also the persistent hypercalcemia. Yeah,
Yes, yes, madam.
yeah.
Yes. On the
And the
follow up,
yeah, yeah.
with
The
the follow
follow-up.
up, yeah, PTH was high, calcium was high.
Yeah. And the other thing is this transporting PTH. Uh, there was that the PTH is transported with melting ice. Melting ice, isn't it?
Yes, madam. In the
Me-
toolbox,
Is it
yeah,
melting ice or dry ice? Because if it's melting, then it comes to the room temperature. It
no,
should be dry ice, as far as I know. I don't
in it's mentioned as the melting ice. Usually, we put the ice packs in the cool box and we prepare the cool box for the transportation.
Yeah,
Uh,
right. Now,
yeah,
Dulani,
yeah.
ready to get like now. Usually, they are transported in ice because if it is melting ice, it is converted to water. No? So the water becomes very soon. It the temperature comes to the room temperature.
Yeah, madam. This is for the actually very short transportation. We advise this, but very if it is
Usually dry ice, no?
yeah, we from
Yeah.
Kandy to Colombo we have to send. We have to use dry ice if it is a long
Yeah.
duration. Yeah.
Mm-hmm. Yes. Okay.
Thank you, madam.
Okay.
Any more questions or clarifications? You can just send something to the chat box if you want. Okay, Dulani, thank you so much for that excellent session. For all Dulani, Faslas, Madhubhashini, and Pirini, thank you very much. And I like to invite Dr. Dilanti, our secretary, to deliver the words of thanks. Over to you, Dilanti.
Thank you, Dr. Kisali. Okay. First, let me thank Dr. Dulani Jayawardana, consultant chemical pathologist, National Hospital Kandy, for guiding the trainees and organizing this event and presenting very interesting cases for us to enlighten us. Next, I would like to thank Dr. Faslas Qumdin, Senior Registrar Chemical Pathology, National Hospital Kandy, Dr. Madhubhashini Rajapaksha, Senior Registrar Chemical Pathology, NHK, and Dr. Tilini Premadasa, Postgraduate Trainee in Chemical Pathology, NHK, for presenting these excellent, very interesting cases. And again, Dr. Dulani, thank you very much for your very comprehensive discussions that you presented. So we would like to, on behalf of the College of Chemical Pathologists, we would like to thank you all and the participants also for attending this webinar today and making the session very interesting by asking questions. So thank you all. and we hope to see you next time with another series of interesting cases in 2 weeks time. Thank you.